All right. Okay, so I think I'm going to go ahead and introduce our first two speakers. Well, Dr. Maurer has been a practicing physician for over 25 years. She is one of the world-renowned experts in HIV and dermatology and infectious disease. She is an international lecturer and researcher in this field. Dr. Maurer earned her medical degree at the University of Calgary in 1987, after which she completed residencies in family medicine and dermatology and 2 fellowships in HIV medicine at UCSF. She served as professor at UCSF in dermatology and was the chief of dermatology at Zuckerberg San Francisco General Hospital for 25 years. Currently, Dr. Maurer is a professor of dermatology at Indiana University and dermatology lead for AMPATH, a consortium of 10 North American universities in collaboration with MOI Teaching and Research Hospital in Kenya. She continues her teaching and research in telemedicine with programs in Kenya, Uganda, India, and Bangladesh, and is working closely with the National Library of Medicine at NIH to examine the intersection of teledermatology and AI. Welcome.
Well, good morning, everyone. It is a pleasure and an honor to be here with you. Dermatology continues to be something that we think about in HIV. Of course, as you all know, really this was some of the most common presenting signs of HIV in the past. And that's what I want to talk to you a little bit about today. In fact, and I'll just go through this, no financial relationships relevant to this talk. And I'm hoping that during and after this talk, you'll be able to think about dermatologic diseases that present an HIV infection, initiate treatment for those diseases, and monitor for treatment pitfalls. So let me begin by bringing up who is still coming in with new HIV diagnoses. What skin conditions might prompt you to do HIV testing? What raises to the level for HIV testing? And then, of course, what vaccines and prophylactic antibiotics should you think about in these patients? And then I want to discuss the old problems, which we thought were old problems in HIV dermatology. We thought these problems would go away with good HIV control, but in fact, we've got numerous diseases in dermatology that just don't go away, no matter what the immune system looks like. So I'll go through some of those as well. Prompts for testing. I'm going to talk about unusually shaped tinea or fungal infections. I'm going to talk about HSV in all the wrong places, as I like to call it. Zoster under the age of 50, Kaposi's sarcoma, still with us, monkeypox, new, syphilis. I know our next speaker will be talking about syphilis a lot, so I won't cover all of syphilis. And then, of course, skin picking in folks who are using methamphetamine, which is something that I think we're all seeing throughout the United States. Let me start with tinea. This is a good illustration of very large fungal infection, as you can see on this patient's back, characterized by well-circumscribed, scaly areas. And please look at this patient's neck. Here you can also see the well-circumscribed lesions of tinea, and please note that there is a little bit of central clearing here. We like to think about central clearing when thinking about tinea, but don't hang your hat on that. What I really want to show you is this large area of tinea. Kind of unusual to have so much tinea, and then tinea on the neck, a strange place to have tinea. And again, here is tinea, more classic. You can see those rings that we see with tinea, and then again, that beautiful central clearing that we see here. Well, when you see widespread tinea, or tinea in strange places like the face and the neck, think about HIV infection underlying that. And so that may prompt you to test for HIV, please. Treatment is still our first line for that kind of widespread tinea. You want to use terbinafine, 250 milligrams daily for a month. But I do want to bring up the fact that we now have emerging resistance, especially if your patients are coming from countries like India, Pakistan, Nepal, and now from Mexico. So even if your patients have just visited and come back to the US, we are seeing that terbinafine is no longer working. We treat for longer than a month. That's our first try. We treat now for about 12 weeks. See your patient back after a month, but gee, if it's not gone, don't be afraid to extend the treatment. And then we're going back to our old antifungals like griseofulvin and itraconazole, sometimes used together because of this emerging resistance. So something to think about depending upon where your patients have visited and where they're from originally. HSV in all the right places and wrong places. Well, this is the right place. Any ulcer in the genital region is HSV until proven otherwise. These are painful, definitely, and you can see on this patient who has this slit-like look of an erosion. That again is HSV. That isn't from anything else except HSV. Some of you, maybe even in the back, might notice that this patient's got some well-circumscribed lesions around that nice slit-like lesion. That, of course, is tinea. And so this practitioner thought that the slit was from tinea and was alarmed when this patient was not responding to terbinafine. And that's because they had concomitant HSV. So again, any erosion, slit-like, round, in the genital area, perianal area, equals HSV. And so treat for that, please. Now, here's HSV in all the wrong places. We like to think about HSV really being in the genital area, but in HIV infection, you can see it all over the place. Fingers are not unusual to see HSV. And again, you see that lovely erosion on that third finger. But please note this nice HSV that you also see on the top of the screen, really characterized by this serpiginous border. We call that serpentine, like a snake. Really nice border with an erosion. And likewise on that finger bottom of the screen, again, please note that serpentine or serpiginous border with an erosion. Again, HSV. And when you see this kind of look in strange areas, again, that should lead you to think about HIV testing. That should prompt you to think about HSV testing. Same with this gentleman who's got HSV on his bottom lip. I mean, this is more than your standard oral labial HSV, you'd all have to agree. And that is, again, not some random infection, bacterial infection, but rather HSV in HIV infection. But this too is HSV, and if you look at that, you might think, well, this guy's got some impetigo. What's the deal? Not responding to PO antibiotics because this is HSV in an HIV-infected patient, can show up anywhere. So if, in fact, you are treating someone for impetigo and they're not getting better, please don't forget that they may actually have HSV. And again, if your patient is not known to be HIV infected, this should prompt you to test for HIV. So acute episodes of HIV we treat with acyclovir or valacyclovir, and here is the dose now, and we treat for a 3-day period of time. There are vaccines that are being trialed now for HSV, and there's a trial in young people even as young as 9 years of age. Even with low uptake and low efficacy, the modeling shows that HSV vaccine could actually be reduced by 1/3. So again, these are being trialed. This is not for common use, but just so that you know, we are looking at HSV vaccines. But a key point is this. We are no longer prophylaxing for recurrent outbreaks in HIV infection, and that may be something different than you standardly think of. In days gone by, we were prophylaxing our patients who were HIV infected with acyclovir long-term, keep it going so they never had another outbreak. We're not doing that so much anymore because of this problem. This is called herpes vegitans. And here you can see what looks like a verrucous-like lesion in the genital perianal area here, and then on the penis. So these are thickened vegetan-like lesions of herpes simplex. Now, when I saw this gentleman under that herpes vegitans, I thought that this patient must have had squamous cell carcinoma. It looked strange. I got the result back from the pathologist that this was, in fact, herpes. And I ran down to the path lab. Oh, you guys made a mistake. You mixed up some specimens. No, no, no. This was herpes vegitans, one of the first cases of herpes vegitans. What is herpes vegitans? Well, like I say, it's verrucous HSV. These are usually acyclovir resistant and is emerging as a problem worldwide, probably because we put our patients on these suppressive doses of acyclovir, selecting out mutations. And this is a mutation of HSV. So, again, please treat acute episodes acutely. Stay away from the suppressive acyclovir that we were used to using. And how do we treat this verrucous HSV? Well, we treat with either injectable or topical cidovavir. And here is a patient who came in with this very fleshy verrucous type of herpes vegitans, and really within a few weeks, with an injection of cidovavir intralesionally, this completely disappeared. So again, that is the treatment of choice for acyclovir-resistant HSV. Now this angry-looking patient, because she's been waiting for hours, is a patient who's got zoster, as you can all see, dermatomal eruption of blisters. Not uncommon. But I do want to point out that zoster in HIV can be looking like this. That is monomorphic. If you'll please note that these blisters all look the same. So that's a typical look in HIV infection. Now, in non-HIV infected patients, what we get with shingles or zoster is a non-monomorphic look. We've got some crusts, we've got some blisters, we've got some red areas. Not so in HIV. So again, if you're seeing a patient who presents under the age of 50 with zoster, they deserve and should get an HIV test, especially if they've got this monomorphic look of zoster. And of course, the zoster vaccine is available, and available to our patients who are living with HIV, and that is, of course, the Shingrix vaccine and 2 doses, and now we're giving it to persons who are 19 and older. So we're not looking at 50-year-olds here. We're looking at 19-year-olds with HIV. Go ahead and give them the zoster vaccine. Kaposi sarcoma is still with us, and many of us remember the good old days when we saw a lot of these purple patches and plaques, and I see people nodding their heads. This, of course, was one of the first presentations of HIV back when I was at UCLA in public health. I think that was 1981, 82, that we started to worry about these purple patches. And we're seeing this again, sometimes as a first presentation of HIV, but many of us have forgotten that Kaposi sarcoma is there. And, you know, these don't necessarily present as huge purple tumors that we think about, but rather these kind of nice purple patches that sometimes patients don't even realize. So again, please be on the lookout. Sometimes you'll see a more defined plaque like you do in the picture next to me. Anyway, if your patient does come in with these purple lesions, biopsy them, have your dermatologist biopsy them, please. And if it comes back as KS, Kaposi sarcoma, you should check for HIV, but please realize that not all persons with Kaposi sarcoma are HIV infected. So we are seeing people come in with KS, which starts from the HHV8 virus. HHV8 virus is everywhere in the world. Patients are showing up with KS lesions, and that patient that I showed you here with this purple plaque, she was from Korea, where there is HHV8, and she had been tested probably 6 times for HIV. It's okay. You don't have to have KS and HIV together. We do know that HIV turns on KS, but there's a lot of HHV8 throughout the world. We're even seeing HIV negative gay men in large metropolitan areas who are HIV negative but have KS. So something is turning on their HHV8 to become KS lesions. If your patient is HIV infected and they have KS, you gotta ask about systemic symptoms. Are you coughing up blood? Are you pooping out blood? Do you have swelling? If the answer to any of that is yes, those patients need chemotherapy and need to be monitored carefully. If they are HIV infected, but they don't have the symptoms that I just spoke of, you can be free to start them on ARVs and wait for resolution. We see resolution in an average of about 9 months in patients who do not have systemic signs of Kaposi sarcoma. So again, first line is ARVs, making sure that your patient's ARVs are really controlling their HIV, waiting 9, even 12 months for resolution of the KS. In HIV negative patients with KS, give us a call and I'll leave some information there. We are not too brilliant at knowing what to do with this group. Again, we don't want to give them HIV meds. They're not HIV infected. So we are injecting local chemotherapy. We're starting things like CCR5 blockers. We're injecting them with local PD-1 inhibitors, and we'll be presenting some of that information at CROI, actually, both in HIV positive and HIV negative men. So here is something more recent that we have seen. These are painful bumps, papules in the anal area, perianal area, and elsewhere. You can see that nice little papule on a red base. This is, of course, monkeypox, Mpox as we call it. Sometimes these can become eroded. That does not mean they're super infected, but rather these erosions that we see, very painful for our patients who presented with Mpox. And there's always Mpox in the environment. If you suspect Mpox, you can certainly talk to your local health department and get a PCR kit. Again, if your patient is coming in with Mpox and not known to be HIV infected, this should prompt you to test for HIV. TPOXX is the treatment for high-risk individuals, which includes HIV-infected patients, so please test and make sure. Not everyone who has Mpox is HIV infected, but those who are deserve TPOXX treatment, which you can get, again, from your local health department. And of course, we do have vaccines available for MSMs and persons living with HIV. It's a 2-dose vaccine, several weeks apart, and you really do get maximum protection once you've had the series of 2 vaccines. Now, when you see these very erosive lesions that just aren't responding, to TPOXX, for example. You got to think about what else might be going on there. And in this case, this patient has concomitant syphilis. So something to think about. If your Mpox patient is not getting better, something else might be happening. And we have seen these very difficult to treat cases in patients who have both Mpox and syphilis. So HIV test for sure. Check it out, confirm whether or not they have Mpox, but don't forget to check for syphilis, because that may be one of the bigger problems here. So, test, please. Now, speaking of syphilis, I'm not going to spend a long time on syphilis because I know you'll cover it both after this talk and in the afternoon, but I always like to show these ham-colored lesions that we talk about in syphilis on the skin. But mostly where I find syphilis is usually as almost an afterthought. Patient will come in with what looks like a drug reaction, but they haven't started any new drugs. They're not itchy like you should be in a drug reaction, and then it hits me. Aha! That could be syphilis. So don't forget, a drug reaction that doesn't itch, now this isn't 100%, but something that looks like a drug reaction that doesn't itch, please check for syphilis. Again, you know the treatments for syphilis and the prophylaxis for syphilis, now with doxycycline, and perhaps good things to think about for sure. But I want to show you this patient also coming in with what looks like an inflammatory, weird look. Drug reaction again, thinking about drug reaction. And then, of course, I did a biopsy, and we saw the wonderful look of syphilis under the microscope. So again, it always hits me almost as an afterthought. It should be a pre-thought, but often not. And same with this patient. Came in, we treated this patient for hand eczema until the cows came home. Failed everything. But lo and behold, this is syphilis. So again, syphilis still is the greatest mimicker around, and this is what you can get. So if your patient's not doing better with whatever you think they have, always look for syphilis. Now, many of our patients are using methamphetamines, and they end up picking their skin. These patients come in with basically holes in their skin, and they want some relief. And what is the relief for this? Well, many of us just hand out antibiotics for these patients, kind of treating them like they have something bacterial going on. This is not bacterial. This is 100% skin picking. This is what your skin will look like if you pick it out. And persons on methamphetamines have this desire to pick their skin. Now, what's the solution? Stop methamphetamine. That's kind of hard, and the bummer is, even if you stop methamphetamines, you're still going to have this desire to pick your skin for about 18 months. And so I don't have the solution here, but you know, those of us who are trying to do stewardship around antibiotics, this might be a place not to give antibiotics, although our patients may demand it. Just saying, this is not the appropriate treatment. Antibiotics are not the right way to go. So, who do we see coming in for new diagnoses of HIV? And I have to say, lots of our patients on meth are those folks who are not yet known to be HIV infected, and testing is a good way to go. Certainly, we're looking at under-resourced persons that have no health care access. That's who we're seeing. And so we're trying to really do a lot of surveillance in our STD clinics, in our FQHC clinics, in our charitable clinics around the United States, where, in fact, look for those skin diseases. We're trying to put teledermatology surveillance into these places so that we can sometimes make the first diagnosis of HIV based on some of these skin diseases that I just showed you. So now let me move on to diagnoses of the skin that persist even in the face of good HIV control. And those include warts, the bane of my existence, because these are like the cockroaches of humanity. They just do not go away. We thought we might get somewhere when we reconstituted the immune system. Not true. These little suckers evade all our efforts. Squamous cell cancer, I'll tell you, we're seeing a lot of squamous cell cancer in our patients who have long-term HIV infection. Kaposi sarcoma. I showed you new presentations of HIV with Kaposi sarcoma, but we are seeing KS in persons who have well-controlled HIV infection. And then don't forget about the common diseases. Our patients are living with HIV, and they have good CD4 counts. They're very immune reconstituted, so now they have the right to develop whatever happens in dermatology, to include acne, eczema, folliculitis, all those things that we really didn't pay a lot of attention to in the early days of HIV, but our patients are now, like anyone else, developing these diseases. So, human papillomavirus, still a great burden. HPV for genital types, do know that there is a vaccine for people living with HIV up to age 26. We're giving the HPV vaccine up to age 26 now. And what do we do for HPV in our HIV-infected patients? Same as we do in our non-HIV-infected patients, and I'll talk about that in a second. Really, we use destructive methods. That is really where we're at, even in 2024. Sodovavir injections have been used and have a low threshold for biopsying to make sure that the HPV on the skin has not turned into squamous cell carcinoma. Let me show you a couple of examples. This is, of course, HPV. This is a wart, a linear wart. And I just bring this to your attention because warts do something called chemnorizing. If you scratch an area or traumatize an area, warts may go to that. So sometimes, though you're looking for these little papules of warts, you'll actually see a line of warts where someone has scratched their skin. That is not abnormal and can be used as a clue to the fact that this person has HPV on their skin. And of course, here's your more classic looking wart, these papules, verrucous papules, so characteristic of HPV. So treatment for cutaneous HPV, lots of treatments. Sadly, they're all about 50% effective, so that's a toss of a coin. We use liquid nitrogen. The average number of treatments for liquid nitrogen, anybody know? Any thoughts? How many times does your patient need to see you? The average is 12 times. So in case your patient thinks you're a quack and bringing them back every time, this is something to tell your patients. Folks, it really does take many treatments to try to destroy your wart. We, of course, are not getting rid of the HPV virus, but we're just destroying the wart. We use a combination of liquid nitrogen and podophyllin, particularly on the mucous membranes. That seems to do well. So we'll do what we call a 1 or 2 times 15-second thaw and then paint podophyllin on and then have the patient wash that podophyllin off in about 8 hours. Candidal injections, the theory here is that we shoot candida into a wart and then the immune system eats the warts. This is only good if the immune system is reconstituted. So in persons who are not virally controlled, this won't work. But whatever you do it every 3 weeks. That's the only evidence that exists, so keep going at it. Like I say, average of about 12 times. Genital warts, I'm always asked about imiquimod. Can that be used? Yes, it can. Does it work? No, about 50% of the time, yeah. So every other day for 12 weeks, return in 16 weeks, and then destroy the recalcitrant warts. Now, here was a patient who had a wart, but something went awry. I hope you would all realize that This is not what a normal wart looks like. This is HPV that has transformed into squamous cell carcinoma. And again, I was sent this patient, please do something about their perianal warts. Well, you can see these erosions in this massive area. This is not just warts. This is already squamous cell carcinoma. And here we would biopsy in multiple areas, send that off to the lab, and treat this patient for squamous cell carcinoma. And this patient came in with what looked like a wart on the side of the mouth. And I kept treating this guy because, you know, I've told you 12 times. The guy came in probably 12 times, and then he demanded a biopsy. And I thought, oh, overkill, why is he bothering me? But of course, this was squamous cell carcinoma. So again, have a low threshold. If your patient really isn't getting better or this thing is looking very funky, time to biopsy for squamous cell carcinoma. And this too is squamous cell carcinoma. This was an original squamous cell carcinoma on another part of this patient's body, and then he developed this very erosive squamous cell carcinoma. This is not unusual in HIV. This patient as well. This is recurrent squamous cell carcinoma in a patient who had a previous squamous cell carcinoma. And this is just to say that there's a high recurrence rate of squamous cells in patients who have had squamous cells and are HIV infected. So please have a very low threshold for biopsying these patients. Metastatic squamous cell carcinoma is a real thing. High-risk areas involve the temple area and the lips. So again, these two patients that I just showed you died of metastatic squamous cell carcinoma with CD4 counts over 500, virally controlled completely, but died of metastatic squamous cell. So this is something to be concerned with in HIV. Now, this is a little ditzel. And again, this patient came in, and I thought, oh, yeah, what, I don't know, maybe it's a red spot. But the patient said to me, you got to biopsy this, because I know I had a partner who died of Kaposi's sarcoma. You got to biopsy this to rule out Kaposi's sarcoma. But this guy was completely virally controlled and had been for years. I was like, what? How can that be? And of course it was KS, patient, gotta listen to your patients. CD4 counts, we started reporting this many years back already. These are patients who are virally controlled, CD4 counts between 500 and 800, virally undetectable for years. In fact, their CD4 nators were never less than 300. But it looks like these folks have had aging of the immune system, so that these people are looking like what we call classical KS, which we see in old Mediterranean men. The thing is, these are not old people, and nor are they from the Mediterranean. They are our patients who are virally controlled for years. Now, in Africa, and where East Africa in particular, where I work in Southern Africa, KS is still ravaging people like crazy, men, women, and children. And you can see here this woman, 24-year-old, 12-year-old boy, 30-year-old men, coming in with these very virulent-looking KS tumors from which there is a 40% death rate. So we are taking out generations of people with KS. And in this country, where we do have chemotherapy, which we initiate pretty quickly in our patients who have systemic signs of HIV, we're doing better. 40% death rate, it's probably closer to a 25% death rate. We get rid of the KS, but sadly, we never get rid of the lymphedema that these patients have. So KS gets into the lymph node areas and destroys and scars the lymph system. And so patients end up with terrible woody-like edema that goes way up into their scrotal area, sometimes into back area, but their legs feel like a piece of wood. And we are doing everything we can to figure out what to do with this group. These are tough, tough patients. We do compression. This is the middle picture, compression with an Una boot. Happy to talk about how to place those, but do know that even with a cure of KS, we are seeing persistent lymphedema. And the problem with that is persistent lymphedema opens patients up again to long-term sequelae, and that long-term sequelae is squamous cell carcinoma. So again, here are two different patients who had long-term lymphedema from their KS. They no longer had KS, but developed squamous cell carcinoma from which they died. So again, this is a very serious consideration. I wish I had all the answers. I do not, but please know that we have multiple approaches now to KS, trying different chemotherapies, even pomalidomide, starting PD-1 inhibitors, nivolumab, et cetera. Controlling lymphedema seems to be critical in these patients. So please, contact us. I bring that up. Let us know at the San Francisco Department of Public Health. We're working furiously to try to do that. The NIH through the AIDS Malignancy Division. KS Centers of Excellence are popping up, and please know you can certainly call me anytime. And there's my email. I'm very happy to help with ideas of KS. So thank you so much for your attention. Appreciate it.
Thank you so much, Dr. Maurer, for just really reminding us of all the things we do need to be very mindful of going forward. So we've got a little bit over 10 minutes, I think, for Q&A. Please, everyone, come up to the mics, or if you want to jot your question down, great. Go ahead.
Hi, thank you so much. That was amazing, and thank you so much for bringing up the meth picking, which is a nightmare. And if you're in any kind of ID anything, these folks keep coming in, and they just keep going somewhere where someone will listen to them because they just can't believe that their bodies are being taken over by every parasite and nobody's helping them, or everybody's giving them antifungals and antibiotics to just get them out. Yeah. And if you just listen to them, that goes a long way, and you test for everything they want to test for. So they'll bring you in something that came out of their butt or their belly button, and it's a bummer, but once they know you're on their side, you can help them, get them into treatment. There's things and meds you can do to help with their meth cravings and such, and it will change everything. But thanks for telling us how long this goes on. So that's
no,
also.
Thank you so much. And that approach is definitely one that we try also. We try to build rapport with our patients so that they don't run away. Probably the worst thing that you can say to a patient who presents like this is to say, yeah, this is from meth, because they just get really angry and upset. So yes, taking them seriously, building that rapport, working with their primary care providers, I think is very important. We do try to get people on psych meds that will help control their thoughts of parasites. These patients will never go to a psychiatrist, never. So you're sort of stuck with primary care and perhaps the dermatologist who's in the know. I will tell you, don't reflexively send these patients to most dermatologists, because most dermatologists neither have the time or patience or training to think about what to do with this group. So call your dermatologist, try to work with them, but it's really primary care that I think has the best success rate.
Thank you, everyone, for sending up so many questions. Just so you know, there are a lot of requests, I think, to clarify the insight that you provided around the practices around prophylaxis. I might, though, just to sort of make sure that we're covering other areas, go to this question. Well, can you talk a little bit about whether you're seeing dermatologic manifestations with like currently used ARVs, namely some of the PIs? You know, when should we start thinking that this might be an ARV-related skin issue?
The really great news is we were always afraid of ARVs giving people drug reactions, et cetera, et cetera. I got to tell you, we don't see much reaction from the ARVs, so thankfully, really not. that should not be foremost on one's mind. Look for the actual derm condition that is probably not an ARV-related drug reaction.
Thank you. And then with the herpes vegetas, are you seeing, or is there a lot of evidence talking about resistance to valacyclovir, acyclovir?
Oh yeah, no, by acyclovir resistant with herpes vegetans, I'm also including valacyclovir and famvir, which nobody uses anymore, but those are all acyclovir-like drugs, and those are, patients are resistant to that whole class of drugs. So you've got to go with cidovavir.
Yes.
You mentioned taking people off acyclovir or Valtrex prophylaxis for HSV. How do you actually counsel people you've had on, who benefited from being on these meds all these years, who are really committed to staying on them? How do you actually talk them through?
You are so right. I think, I have the advantage of showing pictures of herpes vegetans, which you may not, but please feel free to borrow that picture and just say, listen, we're seeing some problems with people who have been on suppressive doses for years. So I know you've been on it, but hopefully you're also talking to someone who is well controlled with regard to their HIV. So you can say to them, hey, with good control of HIV, you probably are not going to get the outbreaks that you did at a previous time. So try it. Stand back, and I give them, of course, a huge bottle of acyclovir or valacyclovir. Have this at home. The minute you feel any tingling or weirdness, start it. You don't need to talk to me. You've got the bottle at home. Go for it. Of course, acyclovir and valacyclovir can't hurt anyone, so even if they're not treating the right thing, who cares? But that is a way of going for it.
Great. Okay, I might just pair the next two questions together just to make sure we still have time. Okay, can you talk a little bit about whether you're still seeing a lot of molluscum, and then for people with psoriasis, what would be your pearls, and then for both of these conditions, any thoughts on whether specific ARV combos might be effective or helpful?
Sure. Thank you. Well, the reason I didn't put molluscum in or psoriasis, and I used to talk a lot about molluscum and psoriasis, is we don't see molluscum unless people's CD4 counts under 100. So I've got to say, we're rarely seeing that. Sometimes as a presenting sign in patients who don't know they're HIV infected, but again, under 100, it's pretty rare to see these days. Again, if you do see molluscum, particularly on the face, that should make you have an alert, okay, this patient needs HIV testing. But again, we don't see so much of it. Now, genital molluscum, of course, we see in anyone and everyone, and those are self-limited, and you can see that, and that means nothing. But on the face, think about HIV. Psoriasis is also one of these things. We used to see a lot of psoriasis when people had very bad HIV. We are no longer seeing that. We see some psoriasis in well-controlled HIV-infected patients, but it turns out it's pretty darn easy, much easier now to control those patients with topical therapies. So we are really using our first-line topical therapies in persons who are well-controlled in HIV who have psoriasis. Now, if you watch television, you will think that everybody in the nation has psoriasis, because every 3 minutes, apparently, you can use a new immune modulator to get rid of psoriasis. Turns out that we're not seeing much psoriasis anymore in the well-controlled HIV patient, and you do not need to go to these biologics to treat HIV infection and psoriasis. Topicals will do. So that's the trick there. Good relief there.
Yes, please.
Thank you. Can you talk a little more about the resistant tinea that we've been seeing coming out of Southeast Asia and that was in the MMWR, for example, in New York City, et cetera?
Yes, thank you. Yeah, absolutely. So resistant tinea is really an emerging infection and of tragic proportions in many countries in Southeast Asia. And this has come because of bad stewardship with regard to antifungals. You know that you can walk into almost any pharmacy in most of the world and get oral antifungals. So that has led to this resistance. The other thing that we see in many countries is not real, that is fake antifungals. So fluconazole is cheap and has been out there. There's very little fluconazole in some of the drugs that you can buy. So there might be a little bit of fluconazole in that, again, which has led to massive resistance throughout the world. So we are starting to see patients come to the United States with these resistant forms of tinea. And again, as I said, longer treatment with terbinafine or going back to our old griseofulvin, itraconazole combinations for at least 6 weeks. So that's where we are.
Thank you. Do we have time for just one more quick one? Yeah? Okay. So just a few related questions around Mpox. Have you tried intralesional cidofovir? And then can you just briefly talk about what access to TPOXX might look like now?
Yeah. Access to TPOXX is still not easy. You still have to get authorization, go through your public health departments. That's the only way to really get TPOXX. Yes, we have used cidofovir. We have injected cidofovir into some of these bad, erosive, painful lesions. Not so much because we're trying to treat the lesion, but we're trying to stop the scarring. Some of these big erosive lesions have left people with very bad stigmatizing scars. And so cidofovir seems to have a place there. So you can inject it. We've also just formulated it as a gel to be put on topically, and that really does seem to help. And especially if you see children who have these erosive Mpox lesions, that's where you might want to also put a little bit of cidofovir topically and try to get at least a synergistic effect between TPOXX and cidofovir.
Thank you so much, Dr. Maurer.
Thanks. Thank you. Great. Good. Thank you.